Because we only have a short period of time, I thought that I would focus on MRI because this is something that is new in my practice. And given that this is, people from this conference are from all over the world, this is something that's relatively easy for us to do in the US and might not be easy everywhere. So I thought I would share what we've learned about MRI. I'm going to be describing two studies here that were funded by the Shriners Hospitals for Children in the US. So first of all, for those of you who treat adults, MRI is not controversial. MRI is an essential element of the diagnostic workup for adults with brachial plexus injuries, but it's not routinely used for infants because we've had concerns about sedation, about contrast, and then reliability of seeing these small structures. And so the current standard is still what I learned when I was training in the early 2000s. Serial clinical exam to determine who would benefit from nerve surgery. You see the baby's back month after month, even when they travel far and parents miss work and there's a lot of anxiety. Month after month, we say, we don't know, come back next month, we'll see if you need an operation. And so the primary aim of this study was to develop a quick MRI protocol without sedation or contrast that could identify infants who would benefit from surgery earlier than we could make that decision clinically. This study was a prospective multi-center study. We enrolled infants ages 28 to 120 days, so 4 to 16 weeks of age. The idea being before 4 weeks of age, maybe they would rapidly get better and it wouldn't be worth putting them through the MRI. We also didn't know if there would be more edema, hematoma that might make it hard to view the MRI so early. And then after 120 days, we thought we probably know whether this infant needs a surgery, and probably the MRI is not as helpful. And we enrolled them at these 3 tertiary care centers. The MRI was non-sedated, non-contrast. We used a volumetric proton density MRI, 3 Tesla scanners, so good machines, but this is at this point relatively old technology. We designed this study in about 2016, 2017, and so there's probably even better technology that could be done now than the pictures I'll be presenting you. But the total average scan time was only 6.5 minutes. So we were able to make the babies comfortable and then get them through the scan without needing to sedate them. And then the other point about this study that I want to highlight is this nap time score. So we had our neuroradiologist look at the scans and they gave a point value to each level of the nerve. So C5, C6, C7, C8, and T1 each got a point value. Any level of injury got a point, and then there were more points for preganglionic injuries, fewer points for postganglionic injuries, but the whole thing was added up into a score. And then we looked at the reliability of this score. So we're not looking at the individual nerve roots, we're looking at the overall burden of injury. And we'll come back to that, but I think that's an important point of the study. The surgeons were blinded to the nap time scores, and we just continued our usual follow-up. We saw the babies back every month, and we decided whether they need surgery. And then we looked at the ability of that original nap time score on the MRI to determine what the surgeons chose to do. We started out with 147 families that we approached and ended up with 65 subjects who had the MRI that was readable and a physical exam at 6 months and a decision for surgery. The demographics resembled the demographics of our clinics. You can see lots of neurachus 1 and 2 injuries, which is mostly what we see in the US, and a wide range of race, ethnicity, so pretty similar to just 2 we see in our clinic. These are some of the pictures. I would argue these are pretty good for a baby that's not asleep. We were able to see things like pseudomeningoceles, we could see rootlets, even thickening out into the postganglionic part of the plexus. So here, seeing what it looks like to have a neuroma. So not a pseudomeningocele, not an avulsion, but evidence of neuroma at C6 here. So in the end, like I said, we had 65 infants, 28% of them met clinical criteria for nerve surgery. The surgical group had a median score of 16 on our nap time scale of 0 to 25, and the non-surgical group had a median score of 7. When we looked at the AUC, the nap time score was able to predict the need for surgery with the AUC of about 0.81, which is pretty good. The nap time score of greater than 13 was 94% specific and 61% sensitive for the need for nerve surgery. So in the end, we decided that this was a useful tool in determining the severity and that the nap time score could distinguish which infants will meet criteria for reconstructive nerve surgery earlier than you can make the decision clinically. And specifically, if they had a score of 13 or more, that was 94% specific for the need for nerve surgery. So moving on from that study, we had this data of 65 infants with MRIs and good clinical exams that have presented to clinic very early, right? These are infants that are enrolled in the first early months of life. And so we thought that we could then compare this against our Neurocus classification. So we all know that the brachial plexus birth injury patients are classified by the Neurocus classification, where we describe the severity by the nerve root injury based on clinical exam. So we say that's a Neurocus 1. When we say that, we're in a group like this. If I say Neurocus 1, you think, okay, C5, C6. If I say Neurocus 2, you think C5 through C7, right? But we don't know whether the Neurocus classification really corresponds to the described nerve roots. Is a C5, C6 injury truly a C5, C6 injury? And the nap time study gave us a chance to look at this. So the purpose of our secondary study was to describe the distribution of nerve root injuries on MRI in infants with brachial plexus birth injury to see how the nerve injury pattern on MRI scan compared with the clinical findings based on the Neurocus classification. So what we did is we took the MRI findings from each subject, those forms that the neuroradiologist had filled out telling us what the type of injury was at each level, and we graphed them by the Neurocus type that had been done by the surgeon at the enrollment visit. So as soon as we saw the baby, the treating surgeon made a decision as to what Neurocus group they were in, and we created a heat map of the patterns of injury. And then we looked for correlations between the Neurocus type and the number and severity of nerve root injuries. So we had 68 infants who had completed the MRI. A couple of those didn't have follow-up, so that's why they weren't in the first study. And we found 19 distinct patterns of injury in these 68 infants, 10 patterns of injury just within the Neurocus 1 group. If we look specifically at the group, so these were our Neurocus 1 kiddos. The darker blue is showing avulsions, medium blue showing rupture, and the light blue showing intact nerve roots, based on the radiologist's interpretation. 23% of our Neurocus 1 injuries had a C5, C6 injury. 55% of them had additional nerve root injuries of some kind that we could see on the MRI. And then the remainder had different patterns. 6% of them had all roots judged intact by our radiologist, but we thought that they had an injury clinically. And there was not a correlation between being called a Neurocus type 1 and having an isolated C5, C6 injury. Interestingly as well, you can see here in the dark blue, we had 3 kids that had C7 avulsions and were considered a Neurocus 1 injury clinically. The Neurocus 2 group was also not correlated with having an isolated C5 to C7 injury on MRI. We had 3 C8 and T1 avulsions in our Neurocus 2 infants. Neurocus types 3 and 4, we did a little better. This was strongly correlated with having C5 to T1 involvement on MRI. And you can see much more severe patterns of injury in these 3s and 4s. So in the end, if we look at this whole group, C6 was the most commonly injured nerve root in our cohort, not C5. Infants with a higher Neurocus grade were more likely to have a higher number of nerve roots affected. So that makes sense. Our clinical judgment does hold true. The most commonly avulsed nerve root in this group was C8, and the presence of an avulsion at C8 was predictive of a higher Neurocus grade. So just to reiterate here, in 68 infants, we found 19 different patterns of injury, which really suggests that the pathoanatomy of brachial plexus birth injury is more nuanced than classically described and more nuanced than perhaps my orthopedic brain. For Neurocus 1 and 2, the injury on MRI was often more extensive than we expected based on our exam, which can explain why a proportion of these only reach partial resolution, right? So there are Neurocus 1 patients that we operate on. Maybe those are the ones that have this more extensive injury on MRI, even though clinically they might look the same at first. And the Neurocus classification may not correspond to the nerve root injury, maybe because of neonatal brain and spinal cord plasticity as well. Of course, it's important to note that MRI has not been established as a gold standard for determining the nerve root injury. So we're making this correlation, but we don't know which one is right. And so, if I think about how this has changed my practice over the last few years, I am now routinely offering non sedated MRI if babies have not recovered by 4 to 6 weeks. I have not found this to be a hard sell with parents. Everybody likes to see the injury. And so, I have most of my patients now getting an MRI if they have not recovered. And my surgical decision making is, it's clinically always been based on the overall picture of injury. But when we look at the MRI, I think, again, we have to make decisions on this overall picture of injury, not simply the presence of an avulsion. Thank you. Any questions?
So thank you, Andrea, for this great talk. So for the audience, please feel free to have some questions in the chat function and we'll moderate it. Scott, I think you want to pose the first question, or?
Yeah, so Andy, we talked a little bit about this last week. I think it's an incredibly interesting concept of the fact that maybe we don't operate on too many quote unquote herbs injuries, that the injury is more extensive. And I comment and I question. I mean, Dan, I've always felt that the true C5, C6 injuries typically do get better over time. And then once you have a C7 injury, then even though the physical examination looks like a 5-6 injury, they're more prone to having surgery. You think that that's true or not true?
Yeah, I think that's true. And I think that's something that, we just need to get more numbers to look at. In the initial study, only 20 something percent of the kids had surgery, so we could verify, okay, what was the actual injury that we're operating on. But I think, as we talked about last week, and actually we saw a baby that at the course last week, that if it looks like a C5 C6 injury but it's not getting better, maybe that's because C7 isn't able to help out. In a true C5 C6 only injury, C7 should be able to help and take up some of that function, and maybe some axons are going through C7 to power the biceps, for example. And so if you're not seeing that happen, perhaps it is a more extensive injury, and I would suspect that's true. I just don't have the numbers yet.
Yeah. And we've seen the same thing in what we assume is a quote extended herbs, over 5-6-7, and then you're operating and all of a sudden your C8 is torn. It's typically either avulsed or ruptured. And I think it's just the same. You think it's the same thing?
Yeah, absolutely. Yeah.
Yeah. So Dan is looking up our last, I don't know, 100 micro. Dan, you're on there. And he can probably comment that we really think there is an injury pattern 5, 6, 7, 8, and that's where the injury stops and does not affect 1. See, are you on?
Yeah, I'm here. Can you hear me?
Yeah.
Yeah. Hi, Andy.
Hi.
Looks nice outside. So we looked at about 170 of our cases, and it's really interesting how our data really correlates with what you're finding. So I think part of the problem is the Naracus classification itself. So the Naracus classification, as you described it, is different from the classification Naracus described, as you probably know. So the classification we usually use is somebody else's classification, not Naracus. And Naracus was really intended to be used at 2 weeks of age, not intended to be used at 3, 5, 9 months. And it was not intended to be an intraoperative classification either. It was just a predictive classification, trying to do the same thing that you're doing with the MRI, right? So I think that one thing that I think is commonly misunderstood is an Erb's palsy, and Scott is alluding to this, an Erb's palsy with the wrist inflection is actually a 5, 6, 7, and oftentimes 5, 6, 7, 8 injury. So when we talk about Erb's palsy and we think it's a 5, 6 injury, it's actually all the way up to an 8. And the thing that has happened as a result of the modification of the Naracus classification over time is we've lost the nuance of separating between 8 and 1. So 8 and 1 are not the same thing. The lower trunk is not an entity. 5 and what's interesting is that you found that 5 was not injured. So I'm really curious as to how that happened. Um, because oftentimes that is injured but recovers on its own. And I don't know if that's what you're alluding to.
So injured, right? So injured on MRI at 6 weeks or 8 weeks, what we mean is that you can't see that injury on
Mm,
MRI done at 6 weeks, 8 weeks, 10 weeks,
got it, got it, got it.
which
So
is
anyways,
different than not injured, right? Yeah.
yeah, so what we found is that almost always the injury is more severe than you think it's going to be because of exactly what you said. C7 does help a lot, and it has to do with a lot of the redundancy that's in the plexus. I mean, we can take a contrail C7, right? And it's okay. But C8 can do everything, can do triceps. C8 can do, I don't think I've ever seen it do wrist extension, but there's so many things that these lower nerve roots can do to contribute to the higher nerve roots that we think are higher nerve root functions. And when we looked at our data, there was nothing in the AMS, no function that was specific to a nerve root, which was incredibly frustrating.
Yeah.
Yeah. So anyways, that's my
I
two
guess,
cents.
I guess, Andy, you made a valid point that Dan asked the question that uninjured refers to uninjured on MRI, right? I mean, do we agree or don't agree that the gold standard may be surgical expiration, or you don't think we can even agree when we're looking at a nerve, whether it's ruptured or lost? What do you think?
I think we're gonna have to come up with intra-op plus, right? So intra-op with, whatever your best intra-op decision making is, which for me is using SSCPs plus visual inspection. Other places it's using pathology. I think ultimately the gold standard is whether you were right. You do your reconstruction to a nerve that you say was graftable and it works, then it was graftable. So it wasn't avulsed. I think that's the only gold standard, which is really hard then to do a study on.
Yeah, yeah, yeah. I think that may be true. I just reviewed a case where the surgeon, very well-known surgeon, diagnosed 6, 7, 8, 1 avulsions, and then the kid recovered. So
Maybe they weren't all avulsed.
yeah,
Yeah.
yeah, clearly.
Well, and the other thing we learned last week in Guadalajara is that the availability of either intraoperative SSCPs or even intraoperative stimulation
Yeah.
around the globe is very limited. I mean, we're spoiled because we have, as they refer to it, the fancy USA checkpoint simulator, right? Which they don't have. And in fact, the case that they did on Thursday, they didn't have stimulation. The stimulation didn't work apparently. So I think you're right. We have to come up with something that we believe is gold standard. Hopefully it's not surgical outcome, because that's going to take us forever and a day to figure out. Right? We need something else.
I know.
Andy, some more technical details maybe. So it was an unsedated child was it a 1.5 or a 3 Tesla machine?
3 Tesla at all of the sites.
3 Tesla. And was it one radar or multiple radars?
The data that I showed you was one radar. And they did a lot of, there were 3 neuroradiologists that participated in the study, and they did a lot of consensus building, and there was a smaller group that they did, intra-radar reliability on, and once we got that to be high enough, then they each just read their own sites. It took
Okay,
a lot. I mean, we joke that the surgeons didn't have to be blinded because these are not easy MRIs to look at, particularly
Yes,
when you're looking at, is there nerve root thickening out beyond the foramina? Is there T2 hyperintensity? Like those are all judgment calls. But this group agreed with each other. But again, I don't know exactly what the goal, if this is going to match surgical exploration.
yeah. Do you think in a sedated child it would substantially enhance the interpretation?
I
Maybe to
think
have
the only thing
clearer
about
results, or the artifacts were very narrow or very mild artifacts?
Yeah, no, the artifacts were mild. I think in a non-sedated or in a sedated child, you could get more sequences, the radiologists love to add on another sequence and another sequence, and the next thing you know, it's an hour-long scan. And we did have failures. So I'm showing you the kids that succeeded in the MRI. Once we got above 3 months of age, we had a higher proportion of kids that we just couldn't read the MRI, and then certainly a sedated scan, you would have been able to get something.
Mm. So as a summary for the audience, so how did it change your practice? So you said after 4 to 6 weeks in a improving child, you would go for an MRI.
Yeah.
Okay.
Yeah, and it
Andy,
has,
can I ask one more question? I'm sorry.
Yeah.
It was there when the radiologist interpreted it, right? I just saw that. Did they have like a checklist? In other words, what you just said there, I think is important. Like T2 intensity, thickened nerve root. They did have it.
they had a checklist, and there were some things that fell out, and I can't remember exactly what, but there were 1 or 2 things that they thought would be good to look at, and then realized they could never agree on it, so they threw it out of the score. So yeah, they did have a checklist, and then the point scale. Yeah.
Andy,
And
sorry.
no, go, Paco, you go.
See, Andy, of those 70 patients, do some of them got surgery? Do you have the correlation between the surgical findings and the MRI and the examination?
I don't. They did have so 28% of them had surgery, but it was a small number, so we didn't look. And of the ones that had surgery, not all of them had an exploration. Some of them had nerve transfers without an exploration, and so the numbers there I think are too small. And the crazy, we're all friends here. It's a Sunday morning. The crazy thing about this study, I think, is that it might not matter because I think it's, again, that overall burden, the number of injured roots that matters more. So it'll be interesting to see if the score works, but it doesn't correlate with the individual nerve root findings. That's going to blow my mind, but we'll see.
Andy, it would also be neat to take that checklist and apply it to a past cohort of sedated children, right?
That's true.
Or even sedated children that you then operate on, like Paco was saying. That would be, that would be really interesting to do, because then you would know it makes a difference.
Yeah.
I do love the study. Good, Sebastian.
With your talk, I would think that doing an MRI, it confuses you even more. So I think it's so the closer to the truth is what you find in the OR.
Yeah.
The closest, and then you have the exam. If you add something that has not a high rate of sensibility or specificity, so it burdens a little bit everything. So from your talk, I would say I would prefer not to do an MRI.
Well, I think if you're going to do it, I would do it early, because the real power of it is in the 6-week-old that looks like an herbs, but then you're going to find out 3 months later didn't get better. That's the real power of who's going to benefit from this.
And the other thing in my practice, this is an impression because I have not checked yet all the patients. But when I have a child with wrist extension, it's all of them except 2, because they were breech deliveries and had avulsions. None of them needed plexus exploration, and many of the patients with a drop wrist, many of them were C5, C8, but I don't know the numbers. But if I tell the parents, if you extend the wrist, well, I tell the parent that if the wrist, the baby can extend the wrist, the chance for surgery is very low. But if on the contrary, they have some chance of having the surgery.
Cesco, I totally agree with that. The wrist extension is such an important thing for determining lower injuries. I think that's the only thing that we found it didn't correlate with a specific root, which is interesting in our study, but it certainly correlated with more than a 5-6 injury. Yeah. So I think, Andy, your work is really, really important, and I think in some ways it highlights just how bad we are and how different we are at intraoperative examination and what our criteria are. Because you can kind of in some way standardize the MRI, but what you can't standardize is examinations intraoperatively, dissections intraoperatively. I mean, I've been in many cases where it's completely surgeon dependent. I mean, intraoperative dissection is as variable as an ultrasound, you know?
Yeah.
It's
So,
very
so,
operator dependent.
so Z, let me just comment on that too. So after we left Guadalajara, a bunch of experts from around the world did a baby, right? And they didn't have stimulation because stimulation wasn't working. Everyone agreed that C5 and C6 were ruptured. That was a given. Everyone agreed. It was all these people. Jorge was leading it, and Renee and Bati was there, and everybody was there. Now, C7, a different story. It was quote unquote elongated. Now, I don't know what you know, but I don't even know what that term means, right? So all the Americans thought it was avulsed. And in the end, the consensus, or not the consensus, the majority is a better way to say it, felt that it was stretched and still in continuity and giving some function, so they left it alone. You and I would have taken it apart. We would have graphed it to 7 for sure. But there is a classic example of a bunch of experienced surgeons looking at a baby pre-op, because we saw the baby pre-op twice actually, and looking at the child intra-op and arguing about a nerve root that could not be correctly interpreted without some other form of assessment, either pathology or stimulation. So I think it's incredibly powerful that that happened just last week.
Yeah. I think another issue, Andy, maybe you can comment. I think also a problem of legal implications, maybe, at least in our country. So if you have an MRI, which says there is something or might be something, and maybe the radiologist was not as experienced as your one. So what do you think? It might be a problem maybe in clinical practice, or
I don't know. I
you
mean,
don't see any legal implications for that if you have an MRI which might not correlate with the clinical findings?
I haven't this group that did these MRIs at the 3 hospitals have not had an issue with it, but I wonder if that's why, maybe one of the reasons why parents are so happy to have this done. You know, maybe they want proof of what the injury was. I don't know. But we haven't run into any legal trouble since we started doing these.
Yeah.
Sebastian, there's one question in the chat. So Andy, what the question says is that we use elbow flexion as a determinant for exploration, whatever time limit you use, right? Do you have an age limit for restoration of wrist extension or not restoration of wrist extension that you use for surgical intervention similar to elbow flexion? It's a good question.
That's a good question. I think I don't personally look at the timing of wrist extension recovery, but I do agree with Dan that you know is and with Paco, that's a sign of a worse injury and something that might make me think, okay, you know, think earlier on that this baby is going to need an operation. But I haven't, and I feel like oftentimes it just doesn't get better, you know, and so yeah, I haven't used that as an age limit. I think, you know, we use the biceps as a marker of the upper trunk because it's easy to look at. Oftentimes, though, as you know, as we've all been talking about, we're operating for other reasons. We're operating to get shoulder function back. We're operating to get wrist extension back, and just using the biceps as the easiest thing to look at.
Okay,